Is being recorded because it is a public meeting. The recording will be posted on the advisory committee's webpage shortly after the meeting. For everyone's reference, today's agenda can be found under the first tab in the materials. And as a reminder again, if you're a member of the committee, please accept the invitation to join as a panelist. Welcome advisory committee members. It's now 2:02. And I'll call the June 6th meeting of the Advisory Committee on Data Issues in the Advisory Committee of Healthcare Providers and Carriers to order. My name is Mandy Weeks-Green. I am the Acting Boards and Commissions Director, and I would like to give you a warm welcome to everybody joining today. I look forward to engaging with each of you in this exciting work. We'll start with a brief overview of the agenda, and we'll begin with roll call. But I would also like to take this opportunity to allow members to get to know each other more. When your name is called, also please let us know what is your favorite fun thing to do that you have planned for the summer. And then we will welcome a new member to the data committee, and then we'll hear public comments. And after public comments, there will be a presentation on primary care claims-based measurements recommendations by Dr. Judy Zerzenfuel of the Primary Care Advisory Committee. And then Joseph Dielman of the Institute of Health Metrics and Evaluation will present on the board's new analytics support initiative. Finally, Ross will present and lead discussions on phase 2 of the cost driver study in Washington and provide a visual for the potential display of the upcoming dashboard. I encourage committee members to ask questions and provide feedback to facilitate our discussion and recommendations to the board. Thank you all for your time and efforts. Turning to roll call, I will call on members by first name in the order listed in the agenda, which is alphabetical order by last name. When I call on you, please unmute your microphone and let us know you're here and what is your favorite fun thing to do that you've planned for the summer. And then please mute your microphone again. From the Advisory Committee on Data Issues, Krista.
Hello, everyone. Krista Abel. My favorite thing to do is to hike the Puyallup Loop Trail with my golden retriever.
That sounds like fun, Krista. Thank you. Megan. Megan. Amanda.
Hi, good afternoon. Amanda Avalos, Deputy for Enterprise Analytics at the Healthcare Authority. And my exciting summer plans, I'm going to go to Victoria, BC, and I love that town, so I'm excited to go.
So beautiful. Allison.
Allison Bailey, let's see, with multi-care, I guess my favorite thing would be to just sit outside and enjoy the beautiful weather.
Thank you. Jonathan?
Yeah, Jonathan Bennett, VP of Data Analytics and IT Services at the Hospital Association. One of my favorite things to do in the summertime is take advantage of the Puget Sound and do a lot of kayaking.
Bruce?
Hi there, Bruce Frazier, Peninsula Community Health Services. Looking forward to a family trip to Hawaii to do some snorkeling.
That sounds wonderful. Jason? Jason? Chandra? Chandra? Leah?
Hello there, Leah Hole-Marshall from the Washington Health Benefit Exchange. I would agree. Kayaking is one of my favorite things to do, so I'm hoping to get out on water.
Thank you. Li Chao?
Lee, Washington with OIC. I'm the chief actuary with OIC. My favorite thing to do is hiking at the Olympic National Park.
Beautiful. David?
Yes, David Mancuso with the Department of Social and Health Services Research and Data Analysis Division. I would also add hiking, but throw in fishing in the Olympic National Park.
Excellent, thank you. Anna? Anna? Hunter?
Here, health economics consultant for Health Trends, and love doing hiking and exploring all around, but something I'm excited to do is finally getting a chance to go out to the San Juans. Been all around elsewhere, but that'll be something new for the summer.
Excellent. Thank you. Mark? Mark? Russ?
Hey, good afternoon. I am Russ Schust. I'm the Senior Director of Medical Economics for Optum Care, Washington. And this summer, my wife and I have made a decision to go camping a lot more. The weather's been beautiful and we've been out twice in the last month, 2 weekends.
Tent or car?
We have an RV that we acquired that we take. It's super fun, brand new for us. It's a new thing to do.
That sounds like fun. Mandy?
Hi, it's Mandy Starr with OFM, and I'm looking forward to, I have a hammock set up, and I'm looking forward to laying in that and catching up on a lot of reading this summer.
Julie? Julie? Okay, turning to the Advisory Committee of Healthcare Providers and Carriers. Bob?
Hi, I'm Bob Crittenden, and my excitement this summer is my daughter's 50th birthday. I'm going to.
Oh, wonderful. Justin? Justin? Paul? Paul? Oh, I see Julie just has some technical issues. Jody? Jody? Louise?
Hi, I'm Louise Kaplan. I am here representing ARNPs United of Washington State. I'm a family nurse practitioner. And I already did my most exciting thing, which was I spent almost 4 weeks in Nepal doing a couple of different treks, but I intend to spend the rest of the summer hiking here and going to the Tetons.
That sounds amazing.
It was.
Stacy?
Hi, Stacy Kessel. I'm the CFO and Chief Strategy Officer for Community Health Plan of Washington. And something I'm really looking forward to this summer is we're bringing in all of our extended family to vacation at Suncadia for my parents' 60th wedding anniversary.
Oh, that's really special. Ross?
Hi there, Ross Lawerson. I lead our Health Economics Committee at Premier Blue Cross. Missed the question, but I get the gist. Intently watching the weather actually right now because I'm hoping to go kayak camping this weekend, and it's starting to look like it might rain, and that's not great. So, but anyway, thanks.
Excellent. Justin, I saw your note too. Thank you. Todd?
Good afternoon, Todd Lusheen, Market President for Pacific Source Health Plans here in Tacoma. We bought Vespas last year, and I'm looking forward to spending more time cruising the South Sound and on them this summer.
Excellent. Vicki? I did receive a note from Vicki that she might be out. Mike? Mike? Natalia? Natalia? Megan? Megan? Mika?
Hi, Mika Sinanan, surgeon, WSMA past president. And I'm really looking forward to a little bit of rain. This sun is starting to get me seriously depressed. But I'm also looking forward to some woodworking, which is an indoor thing, you know, so you really need some bad weather to be able to be effective at that. On a separate note, Jonathan Bennett and I have a draft motion that we would like to raise towards the end of the meeting. So we're asking for 2 or 3 minutes reserved on the agenda, please.
I'm sorry, you and whom?
Jonathan Bennett on the data committee.
Okay. Dorothy?
Hi, happy to be here today and hear all you guys' voices. One of the things I'm looking forward to this summer is a road trip along the Columbia River Gorge from along the whole Oregon-Washington border. So that's what my next upcoming fun thing to do is.
Thank you. Wes?
Hi, good afternoon. Wes Waters, CFO, Molina Healthcare Washington. I'm very envious of a lot of the things that I've heard. So congrats to everybody that's having so much fun. Looking forward to traveling with my wife overseas in August. Spend some time together.
Thank you, everyone. All right, turning to tab 2, please join me in welcoming Krista Abel to the Advisory Committee on Data Issues. Krista is the Financial Contracting Director with Virginia Mason Franciscan Health and has over 25 years of experience in the healthcare industry. More information on Krista is available under the second tab in the committee book. And thank you again for joining the Advisory Committee on Data Issues.
Thank you very much. Nice to join. Appreciate it.
Wonderful. We'll turn now to public comments. And you're welcome to turn to tab 3 in the binders, but we have not received any public comments since either of the last advisory committee meetings. We do allow individuals to sign up for public comments ahead of the meeting, and we'll start with those that have signed up to provide public comments. However, there is currently no one signed up to provide public comments. But if you've not signed up and you would like to provide public comment, please raise your hand and I will call on you to provide public comments. And when I call on you, please state your name and affiliation before speaking, and please do not raise your hand more than once. This helps ensure that everybody has a chance to speak. We also welcome email comments at any time, and please remember that this is a time for public comments, and any Q&A sessions during the meetings are reserved for advisory committee members only to ask questions. And I see the raised hands of Katerina LaMarche.
Hi, thank you. Katerina LaMarche from the Washington State Hospital Association. Wanted to thank you for the opportunity to provide comment. At the last board meeting in April, the state's consultants gave an overview of how providers would be measured against the benchmark, but it didn't really address details that we would consider to be pretty critically relevant to providers, and that left us with quite a lot of questions. For instance, questions related to methodology, how providers are attributed and whether there's consistency across plans, questions around data accuracy, how to ensure that plan data is accurate and verifiable, also on risk adjustment and how that's handled for attributable members. And lastly, really whether and how providers will be able to analyze the data and their performance in order to undertake reforms, if they do exceed the benchmark. So I feel like clarification and further explanation would help facilitate for a better understanding of measurement and expectation. And, we really feel like that's important for providers, and their ability to meaningfully participate in this process, because, without a good understanding of how they'll be measured, providers who exceed the benchmark, won't really have a clear idea of what adjustments to make in care delivery to meet the benchmark in the future. So I'd also say it's worth noting that there's still isn't a lot of clarity around which providers will be considered large entities. So considering what's at stake, we really feel that providers should know, whether they're subject to the benchmark. They should be able to understand how they're being measured, and really trust that the data findings are reliable. And for that reason, we would ask that you seek further clarification of the benchmark methodology. I want to thank you again for the opportunity to provide comment, and happy to answer any questions if anyone has them.
Thank you, Katarina. I don't show any more raised hands, but did someone briefly raise their hand and then lower them? Jeb Shepherd, I see.
Yes, good afternoon. Jeb Shepherd, representing the Washington State Medical Association and its 12,000 physician and physician assistant members across the state of Washington. Just want to be briefly on the record echoing Ms. LaMarche's comments just now. We're a couple years into this process, and there's misalignment among stakeholders in terms of understanding the methodologies that'll be used in terms of attribution, for example, which entities are subject to the benchmark, and what measures are in place to ensure data accuracy. We think it's critical that we understand as the associations these finer points so that we can help our members be successful under this paradigm. As example, and as was noted, there is a benchmark in effect for this year, but to my knowledge, the large provider entities that are subject and will be publicly reported against that benchmark at some point have not been informed of that. And so at this juncture, we would urge the board to provide more detail for public review via presentations at the board, but also importantly, written materials for stakeholder review so that the providers that are subject to the benchmark can understand their performance and how to adjust that performance going forward. Thank you very much.
Do not see any hands raised. Okay, great. All right, thank you all for providing your public comments. Next, we'll turn to Dr. Judy Zerzendul, the chair of the Primary Care Committee, who will present primary care claims-based measurement recommendations. Welcome, Dr. Judy.
Hello, and I can't start my video because the host has stopped it, but I am super fine to not have my video on. But if you want me to, something different will have to change. But
we'll give you, we'll start it again right now for you.
Okay.
You should have permission now.
Ta-da!
There we go.
There I am. Hello, everyone. Not that anyone else is on, but you know, it seems more fun to look at a face that's talking rather than a blank square that's talking. So I'm delighted to be here today in front of both of these committees to talk about what the Cost Board's Advisory Committee on Primary Care has been up to. So next slide, please. So we have been working on definition of primary care. I think many of you have seen that, although we've made a couple of tweaks. Data and policy, and then some talk about the committee charges. So this is going to be the way, and I think you're driving, so I think one more click of the slide. We've divided it, oh no, I guess not. We've divided it into these three areas. So this is how I will dive into the agenda. And I think maybe questions are best after each section of this. So first, primary care definition. And now you can skip ahead 2 slides. And so in the legislation, our committees to recommend a definition of primary care and then recommend measurement methodologies to assess claims-based spending and non-claims-based spending. And we have made some really good progress on that since I've last been in front of you. So the main framework we've been using is thinking about who or what is primary care is that it's really these three things. It's the who is a primary care provider, the what is the service primary care, and the where is the facility considered primary care. And if these three things are all a yes, then that counts towards the primary care program. As we have gotten closer to our claims-based primary care, there may be some changes. It's not super clear that the where is always going to need to be there, but the who and the what are absolutely important in the base of this definition. Next slide. So we got some feedback and we have changed the definition slightly. You may remember that this definition was made as sort of a merging of the BRE and the National Academy's definition. And the one thing that we've added is the why. So the why part of this is to support patients in working towards their goals of physical, mental, and social health and the general well-being of each person through illness prevention and minimizing disease burden. And so that bit has changed, which I think is a nice addition. And this is our definition. Next. So one place that we have talked about is this narrow versus broad for types of providers. So as you may remember, the analysis that OFM did in the past had both a narrow and broad definition of primary care. And so in our measurement thus far in Washington State, we have had those. And as we have talked through our work as a committee, we've worked to refine both the broad and the narrow definition of primary care. And in looking at other states, it turns out that most other states don't do a narrow and broad. They just have a definition. And so the narrow and broad are going to be evaluated in the future to see which of these is most important, or if we pick one that's somewhere in the middle towards getting to the 12% expenditure target. Next slide. So in the broad definition of primary care, this includes all the clinicians that you see here. So a registered nurse, an advanced practice nurse practitioner, which can include some subheadings of a psychiatric mental health practitioner, which is a specialist designation, or NP midwife. Also physician's assistants, including a psychiatric physician assistant, counselors, family medicine, internal medicine, psychologists, social workers, therapists, and OBGYN. And you can see there are some specialties that fit under some of these that are also considered primary care. And then here is the narrow definition. So the advanced practice nurse is a primary care provider or a midwife. Family medicine has a narrower set of practices, as does internal medicine. Naturopath is on here, pediatrics, as well as adolescent medicine, physician assistant, and preventative medicine. Mika?
Yeah, thanks, Judy. So I was confused in comparing the broad and the narrow definition. There are things in the narrow definition, pediatrics, geriatric medicine, for example, that are not naturopaths, which are not on the broad definition. I don't know whether they were just assumed to be under some of the sub bullets, but they clearly belong there.
Yeah,
and more importantly, there are certainly elements that are not under the broad definition. For example, think about transplant physicians, nephrologists, cardiologists, GI docs who take care of IBD patients, all of whom, if you ask their patient, the patient that they're caring for, who provides your primary care, they would say the specialist dealing with the principal area of their medical problem. So we want to be sure, we don't want to make this sort of impossibly large, but I think it has to be realistic for what the ground truth is in our patient populations. I just wanted to make sure that we registered that. Thank you.
Sure, and the broad definition should include the narrow definition. I noticed actually as this was showing that there's sort of some duplicates, and we should fix that so that it's clear which fits in there. And naturopath is, according to our state statute, primary care, so it's included in the narrow definition. The committee did talk some about specialists and some of the examples that you raised, and decided not to include those people. So while I understand for certain patients that is true, the committee decided not to include those. So they are not in this definition. And then I think there was another person whose hand was raised. I can't see the hand raising.
Yes, it's Louise Kaplan. I just want to be sure to clarify for the panelists that in both the broad and the narrow definition, there's the terms used APRN, ARNP, and the state licensure is ARNP. Nationally, the terminology is APRN, Advanced Practice Registered Nurse, and there is going to be some discussion about changing or adding that title. But that's the licensure title, and I just want to be sure, because in the previous slide, it has under ARNP, psych, mental health, and midwife, and in this slide, it has midwife. But ARNP is inclusive of nurse practitioners, nurse anesthetists, nurse midwives, and clinical nurse specialists. And the most typical provider of primary care among the ARNPs is going to be the nurse practitioner. There are some licensure designations that are not primary care, for example, the adult gero acute care nurse practitioner. But I just want to be really clear, midwife can be confusing because an ARNP has to be a nurse midwife, and in the state we also have a licensed midwife, and licensed midwives have now had more expanded scope, and they'll be providing some primary care services, particularly around reproductive health services such as contraception, some infections, things of that sort.
Thanks for that. It looks like there's two more people who've raised their hands.
Hi, this is Dorothy Teeter. I have just a quick question. And I'm not quite sure how these definitions are going to get used in particular, because and what difference it makes, but I'm a little bit curious as to why I don't see behavioral health on the narrow definition.
Yes, it's a good question, and there are codes that are on here. So if there are, for example, social workers in a family medicine practice that are doing, this is the first part, this is the who, and so the what is one of the next parts we'll get to. And how these things, there's a question in the chat, are operationalized is the NPIs, the codes are what we put into the claims to come up with a claims-based spend of primary care. And yes, Mika, it is going to be hard to get to 12%, and some things are gonna have to change from how we currently do things, which we'll talk about towards the end of this presentation. But actually how the committee has, we looked at all the other states. I think there's maybe somewhere in the range of 10 or 12 states that measure primary care. And we looked at all those definitions as well as a consensus definition. And Washington is actually one of the more broad ones. Washington and Colorado were sort of, if there's a spectrum, most people are here and we're out here. We've made some changes in the code set that put us a little bit more in the middle, but most people are in a relatively narrow definition. And we've had some conversation about whether we'll be able to compare ourselves to other states and how we do that. But most states have adopted somewhere around a 12% definition of primary care spend. So it'll be interesting to see once we measure this where we end up. Is there anyone else's hand who's raised? So then I'll keep going. So this is the where primary care is provided. So you can see that we've been relatively broad with that. Including primary care clinics that may be on the campus of hospitals, multi-specialty clinics, rural clinics, federally qualified health centers, etc. Urgent care is on here if you are seen by someone in your primary care provider's office, which sometimes happens. And virtual care is on here too, although oftentimes that virtual care is a part of your primary care clinic rather than a distinct space, but people wanted to be sure that primary care does not have to be a face-to-face encounter. Home visits, those, I know we talked about them. I think we decided no, or that they would be relatively rare. The other piece that we talked about in making this definition, and maybe if you can skip to the next one, just to say that we've done an extensive review of procedure codes about what specific services are in here. And we are shortly gonna do sort of a data run to see where the bulk of things go. There were some codes that people were a little bit on the fence on, and we agreed things that were relatively rare or things that didn't come up a lot, that didn't really increase the primary care spend, that we shouldn't put that in because the committee really felt like the goal of increasing to 12% is not to get every penny from everything that a primary care provider might do, but to get the bulk of what a primary care provider does. And also, it turns out, which isn't super surprising, that using the where can include a number of specialists that use similar E&M codes or might use similar things like skin biopsies that primary care can do. And so we really want to make sure that we're targeting sort of, if you think about, is it better to have extra codes that might not be primary care or be very specific and probably leave out some things that aren't primary care? The committee has landed more on the keep a more narrow focus to make sure that things are really primary care. And then pharmacists, I think we talked about pharmacists and did not include them. And again, although pharmacists are definitely part of a team, they often, I'm not sure that they bill through the provider. And I think that's probably an area for us to have more discussion about. So that's the first third of my presentation. I don't know if there are other questions since I've sort of talked about them on the way. The next session is about data to support primary care. One of the things that we felt was important for the committee, as you know, there's a legislative report on the entire cost board that is due to the legislature the end of the summer. And the committee decided to have some conversation on barriers to access and use of primary care, and some of the accountability, because if we didn't talk about it now, it would be another legislative session before some of these questions or some of these ideas came up, and we wanted to start socializing some of these ideas. And so this will be new information for you. Next slide. So our contractors came up with a long list of general data strategies to support primary care. And the committee went through an exercise to develop a ranked list of strategies that were aligned with the initial interest. And over the remainder of the year, the committee will come back to this to discuss in more detail. So this is sort of a first look at things the committee thought was important. And the ideas that are all on this slide all have to do around data. So how do we make sure that we're getting good data and that clinicians have good data? So there are things on here like the EHR as a service initiative, which passed this that we got funding for this HCA did during this past legislative session, as well as investing in things like electronic consent management, maximizing our current data assets, which include the One Health portal and the APCD and the clinical data repository, and then support the master patient index. Next slide. So then this next section, and you can do the next slide, is, I don't know, maybe I'll stop there for a minute. Are there questions about the data piece? Mika?
Yes, thank you. So just to be clear, under the data support and measures primary care slide, the list, the bulleted list are the top choices from your ranked list, but there were more strategies identified. Is that right? Or is this, I mean, how did you choose these off of the ranked list?
That is a good question. I think this is we can go back to that slide if you want. I think this is the list in rank order, and it might include everything. Jean Marie, are you on? Were there things that we didn't put on here? I can't remember.
I'd have to go back and check. Yeah, let's put a pin in that so that before we say for sure. I can get back to you on that, Mika.
Thank you.
Any other questions? Okay, then we'll dive into this last bit. And so also in the legislation, the committee is to recommend methods to incentivize achievement of the 12% target and recommend specific practices and methods of reimbursement to achieve and then sustain those targets. Next slide. So to develop some recommendations, we had a conversation about what are the drivers that influence that primary care spend to total spend ratio. And since our ultimate goal is to ensure access to high quality primary care, 12% is a lever to get there, but isn't necessarily that if we get to 12%, we automatically have high quality primary care. And so we thought it was important to talk about how do you maximize the impact of investment and what that looks like. So we used a 4-domain framework that I'll show in the next slide to explore different strategies for advancing towards that 12% target. And they are here. So the first one is sort of obvious: direct investment, pay more for primary care services. The second is capacity growth. So reduce the barriers so that there's more time spent on patient care by clinicians, and do workforce investment. The third area is patient behavior. So how do we increase patients' use of primary care services rather than, say, the emergency room as a source of care? And then finally, the last piece is reduced expenditure on other services. So there's maybe reduced utilization on other services that might not be needed because there's improved primary care access, or because people get those services from their primary care provider or the office. Next slide. So we did a similar exercise here in looking at, we got strategies from mostly the National Academy's primary care report. And we again ranked these and had people, and these are all of the strategies I know, Mika, and that had at least some support from committee members to work on this. And we thought that this was important to put into the legislative report and to start having larger conversations besides just our committee in doing some of these things. So the first one probably isn't surprising, is to increase primary care reimbursement. The second one is capacity growth, and that means reducing administrative burden or costs on providers to do so that they have more time to spend in patient care. The third one is forgiveness for non-compete clause penalties that are incurred by primary care clinicians who leave a position to work elsewhere. The fourth is patient engagement, and this one is specifically encouraged on employers or whoever is providing the healthcare insurance to a person to somehow support, incentivize, or encourage patients in selecting a PCP. 5 and 6 are both about capacity growth. Expansion of the current loan forgiveness opportunity and working with the education system to keep the pipeline growing. Some of these things are happening already. The seventh one should also have the direct investment in front of it, but is specifically increasing Medicaid reimbursement. 8 is capacity growth, and that one is a multi-payer collaboration to develop and implement payment models that offer greater financial flexibility and incentives while growing access and improving quality. 9 is also under the category of capacity growth, of providing options for practice teams to have a fully capitated system. And then the last 2 are about increasing fee-for-service reimbursement for remote patient monitoring and for care team members, such as pharmacists. So Louise, there's one of your comments, care coordinators, community health workers, and things like that. And I see there's a question in the chat. So yes, the denominator is total healthcare expenditures, as Jean Marie said. I don't know if there's other questions or comments about these strategies. And we'll move on to the next slide, which is just general time for questions or discussion. That is all. Leah.
Thank you. I know this is represents a lot of hard work by you and the committee, Judy. Just it would be helpful context, and maybe offline you could just share with the advisory committee kind of as you laid out these next sets of questions. It'd just be nice to have a work plan, very high level of kind of the activities the committee intends to work through.
Yes, I think that is great, and we will get into that. So the next steps for the committee, we have just started to talk about non-claims based reimbursement and how we measure that, which is going to be super sticky. We had Michael Baylett, and we also had some folks from Oregon who measure that come to our last meeting and just kind of tee up that conversation. And so our next meeting in a couple of weeks, I think, we'll be starting to dive into how do we want to measure those parts of it. So that is things like quality bonuses that are earned, maybe per member per month that isn't tied to claims, different pieces like that. So we'll start to dig into that. And then after that's done, we'll dig into these strategies a little more to flesh them out a bit more and provide some more detail on what we think implementing them should look like. But we wanted to get them out early so that people could talk about them and sort of start to think about them, because none of this is going to be easy. And I think it'll take a lot of conversation to get us to the 12%.
Thank you. Appreciate that.
Mika?
Yes, thank you. You know, reading through these, I was struck that there's a sense of the overall list that it is a sort of build it and hope that they will come. The patient engagement number 4 is really the one that focuses on redirecting patients. And there are a lot of other levers other than employers and those who pay for health insurance that really need to be considered. The specialists we talked about earlier, emergency rooms, inpatient care, and I'm sure other social determinants where we have to get people to be thinking about a relationship with a primary care doctor in a different way. Changing that behavior, as you point out, is a very difficult thing. There's a lot of inertia there, and it's a lot of inertia in our system that directs people towards more expensive care. So I wonder whether 4 needs to be expanded to include some of the other areas and to really think creatively about the ways of changing how patients think about the overall care that they get and how they seek care. Thank you.
Yes, I think that's definitely something that we'll be digging into more once we get to talking more about these strategies, because it will take a village to think about this. Yeah. Dorothy, and thanks, Bob, and for your comment.
Yeah, thanks for this presentation. I have just a curiosity question around the percent of practices, primary care practices in Washington State that are still independent, freestanding versus those that are part of larger systems. Because it strikes me that the investment strategies are going to be different if you're a small primary care practice versus if you're part of a larger system. And you know, I'm wondering if there are very many primary care practices left that are out on their own as opposed to being part of some system.
That is a good question, and I don't know. In fact, it's sort of hard to figure out, which is a little shocking, but how many primary care practices there are, depending on sort of how you define them and what that looks like. So
yeah,
yes.
I know that the Washington Health Alliance probably has some of the best information about that. And it could be, the job might be a little easier about the 12% if most of primary care is in fact part of a larger system, because then you could look at total cost of care and figure it out that way. So it's just super important, I think, relative to, from a patient perspective, you know, to Mika's comments about how you educate and encourage folks. It has everything to do with how you communicate that if they're part of a big system like Providence or a small community health center in a small rural practice. So just a comment, and thank you so much for this.
Sure. Louise?
Yeah, I just wanted to respond to Dorothy's question, which I think is a really important one. The practice that I'm part of is a small physician-owned practice that multiple health systems have tried to purchase over the years. And the physicians who own it keep resisting. Living in Olympia, I can tell you there are very few privately owned independent practices. And I just read in today's newspaper that Olympia OBGYN was bought by Providence and will now be part of the Providence system. So there's one fewer than there was yesterday. And there are also nurse practitioner owned practices. So finding that number is really important. And the other issue that we are struggling to understand is when we talk about the who of primary care, there are some practices that we're told are billing nurse practitioner services under physician numbers. I work in a practice that has consistently said, we can't do that. And yet I'm told by some nurse practitioners that that's what happens in their practice. So the who and who's contributing to primary care is not as clear cut as we would like it to be. So that might be another issue to consider in terms of looking at how one identifies who's providing the primary care.
Thanks, Louise. Okay, well then I will let you move on to your next agenda item and take care.
Thank you for the great information and recommendations. Next, Joseph Dielman from the Institute of Health Metrics and Evaluation will present on the board's new analytics support initiative. We're excited to announce this new initiative, and we're grateful to have this grant-funded opportunity from the Peterson Center for Healthcare and the Gates Ventures. Welcome, Joe.
Great. Thanks, Mandy. Thanks so much for the kind introduction. As Mandy said, my name is Joe Dielman, and I'm kind of excited to present today on a new initiative that I'll be involved with and working very closely with the HCA and hopefully partnering with both the Healthcare Transparency Board, Cost Transparency Board, as well as the SMART committees. So, as far as the time I have today, I briefly give an introduction to myself, talk a little bit about the analytical support unit, and then also talk briefly about a project that my research team has been doing for the last few years, and in some ways is kind of the foundation on which we'll kind of broach this topic. And then we'll end with talking about next steps. And maybe before I go on, I'll just kind of highlight that, you know, the goal today is really about kind of a meet and greet to both introduce myself and the project. And so really excited for feedback and, you know, an opportunity to hear voices from the panels in particular on the directions that this initiative could or should take, considerations that, you know, should be front and foremost on our minds. So please jump in. And yeah, so this is me. I'm associate professor at the University of Washington. I work at the Institute for Health Metrics and Evaluation, leading what we call our resource tracking research team. My background is economics, and I've pretty much always worked in health financing for the last 15 years or so. And as maybe next slide, I'm kind of assuming that not everyone necessarily is familiar with the Institute for Health Metrics and Evaluation, so I wanted to introduce briefly what that is. It's an independent research center at the University of Washington. We have grown over the course of the last, I think it's now 17 years, to have over 450 different employees. It's about 30 different faculty members from the university. And by and large, the Institute is charged with doing work related to measurement and health. And that means some of our major projects are looking at health outcomes and health burden. But a lot of the work that I lead is more looking at resources that are part of the healthcare system. And we do that with a lot of focus on global comparisons. So a lot of my work is, very global and looking with a unit of analysis of countries and years and changes over time. But increasingly, we've also done a lot of work focused in the United States and increasingly focused, quite local areas within the US. And so that's obviously the connection point to the HCA and the Healthcare Cost Transparency Board. So I want to go to the next slide. The projects that we've been doing for the last few years, in some ways, really the last decade, kind of connects very closely with this report that was funded by the Peterson Center on Healthcare and Milbank Memorial Fund, led really by Michael Baylett, that posed the question of what data is needed and how should it be used to inform, essentially provide information for thinking about curbing cost growth. And so that report, which I assume some have seen maybe, and those of you who haven't, it's very accessible online, came out about 2 years ago, really kind of revolves around these very basic 3 questions of where is spending problematic. That includes kind of an assessment of where, as in terms of diseases and services and markets, but it's also intended to look at growth trends and rates over time. The second question is what's causing the problem, just to understand and back out, can we put a finger on why spending is growing more in that space than maybe all the other either services or conditions or markets. And then the last question is who's accountable, who might be able to control some of that cost growth. And in many ways, this kind of framework that was proposed in this report lines up very closely with what we will be doing and have been doing for a while, looking at healthcare spending, and in particular, what we'll be doing now focus more on Washington State. So, in that report is this kind of list of 10 things that Michael Baylett and the other authors kind of recommend simply knowing, simply having access to. And so this is really where our project begins, is the idea that, currently these things, the first 10 in this list really, aren't measured comprehensively across the state. And so that's really the first part of this exciting project, is to take all of the spending on healthcare in the state of Washington and try to describe it using these key metrics. So asking the question of, if we build it up into a small set of markets that we focus on, can we take all of the money spent in Washington State and split it out across that? And then can we look at those trends over time? And our focus really here will be the last 10 years. So can we see how spending by market has changed over time? We'll do the same thing for geography. And so our focus, at least at the onset of the project, is going to be looking at spending by county in the state of Washington. And again, asking the question, if we're looking at per person or per capita, how is that spending in that specific county changing across time? And again, kind of being able to back out some kind of understanding of why it's going up in some places faster than in other places. The next group is looking at service category. And again, the same sort of analysis, kind of identifying outliers and looking at both outliers in the spending level, but especially outliers in the increases over time, followed by health condition, and then finally some work looking at the demographics, the population that health spending is going towards. So that's kind of the first part of this project. That's probably the part that feels most established at this point. It's work that we have done and I'll share some of that research in a minute. It's work that we've done before, not in the state of Washington, but more national, and are doing in some other states as well. But the second part then is to try to have a slightly more sophisticated look at the trends and ask the question, can we focus on some of these categories where there are outliers in spending growth and identify what we think is driving those increases. And I'll kind of share an example of how we've done that in the past in a few minutes. But that's really the second part of the analysis. The project is the project is supported by the Peterson Center on Healthcare and Gates Ventures, which is here in Seattle. And it's really meant to form a partnership between the HCA and the Institute for Health Metrics and Evaluation, where I'm at, as well as the Healthcare Cost Transparency Board, and to ask the question, to what degree could could IHME provide analytical support that would benefit the HCA as well, and especially benefit the Healthcare Cost Transparency Board? The project itself is about 2 years. It's just getting started within the last few days. And again, the objective, this is, in all the grant documentation, really revolves around this point of providing analysis and description of spending to the service of reducing healthcare cost growth in the state. The key deliverables over the course of the 2 years of the project are kind of outlined here. And in parentheses, you'll see the dates on when those deliverables are kind of due. And in some of these cases, it will be me coming back to the committees here and providing information about what we've been up to, what we're finding, the progress we're making, observations, and eventually recommendations as well. And so to kind of walk through the key deliverables, the very first thing to do, in addition to kind of familiarizing ourselves with the landscape, is just developing an analytical strategy that builds from our own capabilities and combines it with Washington state specific data. The next piece is to essentially use research that we've done in the past and focus in on Washington and ask the question, how can our past research inform the spending environment here in the state of Washington? That is, again, using estimates that already exist. But the hope is we can hit the ground running with providing maybe some information that's useful, again, to this group, or specifically, especially the Healthcare Cost Transparency Board. And then moving on, then we start to incorporate Washington state specific data, including the all payer claims database, and in making our estimates more up to date. Again, doing that description of healthcare spending by market, by service category, demographics, location as well. And then finally, towards the second year of the project, it's really taking those categories and starting to try to assess where there is growth, and in particular, where there is growth that we can explain, that maybe is because of underlying disease epidemiology, or simply aging of the population, versus parts of increases in spending that we can't easily explain. And that really, of course, becomes the fodder for more investigation, and I think the opportunity to continue to ask meaningful questions about where spending is going up and why it might be going up. And then the project ends with a formal set of recommendations to the Healthcare Cost Transparency Board. And then well, if you can go back 1 second, the last thing on this slide that I think is really important for me to highlight is that, unlike some projects that at the very onset are very clear precisely what the outcome is intended to be, the analytical support initiative is intended to be somewhat dynamic and collaborative, with the idea that some of what we're going to be assessing is still very much to be determined. And that's, again, why I'm here today is really in some ways getting feedback from this group. And I'll be having a similar conversation with the Healthcare Cost Transparency Board soon. and essentially asking that same question. We have a small amount of researchers who have a pretty sophisticated capabilities and access to a wide variety of data. The goal is to look at growth in healthcare spending, and we want to be answering questions that are useful to the Healthcare Cost Transparency Board. And that, at the very onset of this project, being, June of 2023, where we are now, isn't immediately clear. I think we have some ideas based on work that we've done in the past, but we do really want it to be dynamic and for my group, as well as collaboration through the HCA, to be open to feedback and open to ideas that, kind of represent some of the best ideas or the most important places for investigation. So and maybe to that end, the first slide in this had my email address, and I think you can get in touch with me through Mandy, but also you should feel comfortable reaching out directly as well. So the last little bit of the slides is I'm going to present a project that I kind of mentioned has been going on at IHME and that I've been leading for the last decade. We call it the Disease Expenditure Project. And, I put this kind of, arrow, or this line with arrows on both sides to highlight that I tend to think that most health economic research, and this is especially in the academic environment, tends to be really micro or really macro. And the macro stuff is just, really looking at total health expenditure and maybe growth rates over time, but not really able to dig into maybe demographics or service categories. And then on the micro side, I think there's a fair amount of research that focuses on a single service or a single disease or a single, market or any specific population diving into the VA. And where we like to see ourselves as kind of in the middle of that, we aspire to be comprehensive. So looking across the entire state and all the healthcare spending within the state. But by doing that, we don't want to kind of go so far to the extreme that we don't have any granularity. And so the way that we've tried to thread this needle in the past works really well for some people, and other people don't feel like it's hitting the mark. But again, that's where I think we're eager to take some feedback. What we found is this place in the middle really speaks to policymakers and has been a good, fodder for additional conversations about identifying increases in healthcare spending. And so that spot in the middle that we've identified is to just take total healthcare spending and to, at this point, we've mostly done this at the national level. So looking across, the 4 trillion spent on health in the United States, and broken it up using 5 different frameworks. And we do those, that kind of disaggregation simultaneously. So in the end, we have, fairly granular buckets that can describe where, again, in the case of the US, where that $4 trillion is going. So we have a demographic framework where we're essentially breaking the population up into age and sex groups so that we can age and sex standardize. The next piece is an epidemiological framework or a disease framework. So we essentially group or couple ICD codes that tell us about diagnoses into 161 health conditions that are mutually exclusive and collectively exhaustive. So, essentially all services, or I should say diseases, really fall into one of these categories. I think we're always changing the way, if we dig deeper in certain areas or if we scale up. But, these are, the biggest conditions with highest prevalence and most spending in the state are certainly within this category, these categories, and pulled out things like diabetes or depression or dementia, ischemic heart disease, and so on. We have a type of care framework. So that's looking at inpatient care versus ambulatory care, home health care, retail pharma, dental and nursing facility care, and emergency department care. So those are our kind of 7 different categories that, again, we take total spending and break it across those 7 modalities. Our work, again, is relatively macro and aggregated. So we have a 4-payer system where we're looking at Medicare, Medicaid, private insurance, and out-of-pocket spending. That's the work that we've done in the past. It doesn't drill deeper than that. And then lastly is the geographic framework. So our current work focuses on the United States as a whole and looks at 3,110 US counties. And so the idea is that, again, for this work that we've already done, we can kind of back out and say, okay, in this county versus another county, we see that diabetes spending is going up even after we've adjusted for disease prevalence and age and sex. And it allows you to make some comparisons and maybe ask the questions, is that related to the type of care that's being used, inpatient versus emergency room or outpatient, or is it, can we say this specifically about Medicare versus private insurance or vice versa? So the idea is, again, to try to thread this needle of doing something that's comprehensive and big, and at the same time is granular enough that it can essentially point the Healthcare Cost Transparency Board, point this group into specific places for ongoing analysis and investigation related to healthcare spending growth. So the next slide, the next few slides actually just highlight some of our results, the way that we've presented them in the past. And I'm not going to go into this in a huge amount of depth because it's all publicly available and already published. But this is an example of just a very kind of simple introduction to our project. This is our 161 health conditions. And this is for the United States. This is specifically looking at all payers, all types of care, all age and sex groups. It's 2016 estimates. And it just, it's like a pie chart, but it turns out it's a lot easier to read square or rectangular pie charts when you have 161 slices. So, but the bigger the box, the more healthcare spending. And so this is, where is healthcare spending, that $4 trillion in the US, where is it going? What's it being spent on? And so you can see big boxes jump out right away, like diabetes, ischemic heart disease, back and neck disorder, pain and other musculoskeletal disorders. All the blues are essentially non-communicable diseases. The reds are communicable diseases. The greens are injuries. Purples are the treatment of risk factors like hypertension or hyperlipidemia. And then the oranges is essentially well care. It's healthcare that's not associated with a health burden. So labor and delivery falls into there. Your twice annual dental cleaning fits into there. And of course, any primary care, fitting back with the topic we just had, fitting would fit into that category as well. The last thing I'll point out about this slide, it's very interactive. So if you go to this URL and you want to look at, just Medicare, you want to look at just 65 plus ages, or you want to look at just 18 or younger in ages, you can see this pie chart essentially move. The other thing that's cool about it is that the darkness of the colors highlights the growth rate over time. And so the things that are really dark blue, things like diabetes, low back and neck pain, other musculoskeletal disorders, osteoarthritis, skin, ADHD, those really dark ones are where the spending by disease is going up the very fastest. And so, you can see ischemic heart disease is not dark. And that means, it does represent a lot of healthcare spending in the United States. I think our estimate is right around $90 billion a year on ischemic heart disease, but it's not growing. And relative to some of the other health conditions like diabetes or skin cancer, it's in relative terms actually shrinking. And so again, this is an example of an ability to just start to look at health conditions and ask the question of what's growing the fastest. And of course, we have, well, maybe I'll go to the next slide and point out, this is one analysis that we've done to just start to decompose or understand why the healthcare spending is going up. So this graphic is looking across all healthcare spending, all diseases, all age groups, and essentially attributing cost growth in the United States to one of 5 categories. One is just more people. The neck, that's purple. The orange is an older population. The green is changes in disease prevalence. The light green is service utilization, and the red is price and intensity of care. And if you're looking now at the figure, you'll see the main types of care that our analysis focuses on. And anything to the right of that vertical line that says 0 marks increases in annual spending. So, just to orient you at the ambulatory care, we see between 1996 and 2013, the annual spending on ambulatory care went up by $330 billion. So, a remarkable increase. And we can back out now. Why do we spend more on ambulatory care? It has nothing to do with disease prevalence. That's kind of the first thing. Sure, we're probably less healthy in 2013 than we were in 1996, but that's not overall, after you aggregate across diseases, driving the change. What is driving the change for ambulatory care is more utilization and to some degree higher prices and higher intensity when people do utilize services. A very different story emerges when you look at inpatient care, that in aggregate across age, sex, and cause and location, the essentially bed days per prevalent case has gone down. But at the same time, we do more services and more expensive services in less time. And so what is compensated is an increase in price and intensity. So the black dots are the total increase, whereas the bars explain the increases. I think cool thing about the research is you can dig this and kind of start to look at a wide variety of more focused analyses. So the next slide shows us essentially the exact same thing. Again, this is still at the national level, but it's looking at 3 health conditions. And 3 health conditions that jump out as health conditions that have had amazing amounts of growth to the tune of $40 or $50 billion increases in annual spending over the course of 1996 to 2013. And I think the important part is, again, this is mostly a descriptive analysis to allow us to kind of identify, in very simple terms, what is associated with those increases. And so diabetes, sure, we spend more on ambulatory care, but really, the most of the additional spending on diabetes is pharmaceuticals. And, pharmaceuticals is this kind of perfect story where we have more people, older people, more diabetics. That's the age standardized disease prevalence has gone up. And then per diabetic, there's more use of pharmaceuticals, and per prescription, the price has gone up over time. So you add up all 5 of those things and you get essentially about $44 billion more in annual spending on diabetes. And then if you look at low back and neck pain, no one in this audience is remotely surprised, but it's like totally different. And that's the point, is just being able to quantify where spending is growing and highlight, what is some of the things that we can attribute to that growth. So low back and neck pain is more about ambulatory care than anything else, and it's mostly about utilization of ambulatory care. And then the inpatient care has grown a lot. That's not because of bed days and admissions. It's because of higher prices and intensity of care. And again, you can go through all 161 health conditions and ask how much are they increasing, and which of these essentially 5 factors can we attribute the growth to. And again, I think our project really wants to, in some ways, take away the effect of the blue, the orange, and the dark green, and say, what can we learn about service utilization, price, and intensity of care? That, we're not going to change population size, age, and again, outside of public health, thinking a little bit less about incidence of disease, but really thinking about what's leading to those increases in spending due to utilization and increases in spending due to prices. The next slide shows another project where we've disaggregated this by race and ethnicity. Again, this is at the national level. And you can, this is a publication just highlighting some of the disparities when it comes to health resources in this country across 6 mutually exclusive, collectively exhaustive race ethnicity categories. And then if you go to the next slide, again, you can start to kind of, I say decompose those differences. And so this is just looking at Black non-Hispanic versus white non-Hispanic, the two biggest race ethnicity groups in this country, and saying, well, if 0% is the normal spending, that's the all population normal, how are each of these race ethnicity groups different? And, we can see that if we're, again, just to orient you to the figure, the Black non-Hispanic has this gray bar going down by ambulatory care, which is to say the Black non-Hispanic population in the United States is spending less on ambulatory care, about 25% less than the average person in the United States. And then the blue and the red bars tell us about, is that because of more or less utilization or more or less prices? And so you can see in that first bar that I just talked about, the blue arrow suggests that it's pretty much all utilization. And so it's access is what we're really talking about when we're talking about Black non-Hispanic population with less utilization of ambulatory care. And you can see this across all 6 of the race ethnicity groups. You can see essentially what are the factors associated with more or less spending, which type of care is it? And again, if we want, we can do comparative analyses by disease. So if we're looking at a person, a white non-Hispanic diabetic who's 65, we can make a comparison to the average Black non-Hispanic diabetic the same age and ask questions about on average the care. So I think the next slide is one additional kind of example. This is a project looking at spending attributable to modifiable risk factors. So these are the risk factors that lead to the most spending in our country. And again, it's quantifying that amount. So again, it's really just putting a dollar value on some of these things that we all know to be true. So the modifiable, so we looked at about, I think in this study, like 93 modifiable risk factors. The one that jumps out as having the most healthcare spending attributable to it is high body mass index, followed by high blood pressure and high fasting plasma glucose. Each of those almost at about $200 billion of annual spending per year. I think I have one last example, maybe. Nope, that was the last one. So those are examples of what we've done on our national project. And I think what we're actually working on currently is taking what we've done before and making it a little bit more granular. And so that, separate research project is doing all of what we've done, but instead of doing it at the national level, doing it for each of those 3,110 US counties so that we can compare across states with major metropolitan areas. We can compare within states, rural and urban, or 2 major urban areas, and really just try to identify variation and ask the question of what can explain some of that variation. So again, back to what we're doing in our new project, which is this analytical support unit or initiative, I should say, with the HCA, is, we're trying to do all of that, the exact same thing, more or less, but focused on Washington state. So looking at Washington counties, looking at the Washington population, and really looking at those same categories that are described in the Baylor report that I talked about 20 minutes ago. Our first steps in doing so are to access Washington-specific data that we haven't used in the past. Probably the most important one is the all-payer claims database. So we've are getting access to that currently. Those are long processes. And in addition to other data sets that we haven't used in the past. So that's part of that data landscaping, is just to understand the environment of kind of unique Washington data sources that could inform our study and allow us to make more precise estimates for the state of Washington. And then, number 3 here is just learning. I mean, that's kind of why I'm here today, is to get feedback from this group to understand, what are ideas on how we could push what we're doing to the next level, how it could be most useful. And then very shortly thereafter, we're going to be putting together an analytical strategy document that we will, kind of guide our first year of the project, identifying the direction we want to go, the things we want to be thinking about. So at this point, we don't have that strategy document. The project just started June 1, so we're really just getting started. but I'm keen to hear feedback from this group and excited to see, to some degree, how we can use data to inform some of the things that this group is most interested in and the Healthcare Cost Transparency Board is interested in. So I think that's my last slide. Yeah, thank you, is the last bit. So I guess, we have, at least as far as my time goes, about 15 minutes remaining, and mostly wanted to see if there's any feedback, ideas, constructive suggestions, places to focus. It's a 2-year project and these things take time, but really eager to get input from this group. Amika, go ahead.
Yes, thank you. Very interesting perspective. I keep coming back to the so what question and giving us, I'm thinking, for example, my friend Mike Marsh, who's the CEO at Overlake. If we say at Overlake, your medical center is at 3.6%, then you're supposed to be at 3.2% growth rate. He's going to say, where are my expenditures out of line? Which practitioners, which clinics, where should I focus? What should I do? And you mentioned that you're certainly going to try and get more granular, but that's the degree of granularity that from an operational standpoint, we have continued to struggle with. In previous presentations that this advisory committee has seen, we have tended to look at what the available data is, not the data that we would be able to use and to actually change our systems, but what is available and what has integrity and what is achievable from a regulatory standpoint that we can get access to. And those two are a Venn diagram, the overlap of which appears to be pretty small. So I really appreciate the fact that we're hearing about this early on, because that so what is a key question. And as you continue to work on this, testing it with a group, a primary care, small practice, a small group, a small medical center, a major system, and say, this is what we found. Is it actionable? Do you believe it? What would you need to be to believe it? Does it give you enough granularity? That kind of thing is going to be so important for us collectively, the board and both advisory committees and the primary care committee, to bring forward to have a credible product. And you're only one piece of it, but certainly a big piece. You've done wonderful work in the past at IHME, but often it's not, the actionability is at state, country, over years, as you pointed out at the beginning, not as granular as I think we need. So that's my comment. Thank you.
Thanks, Mika. While we wait to hear from someone else, I'll respond a little bit to that. I really appreciate that push. And I do hope, the project's intended to be that dynamic, collaborative objective, with the idea that let's essentially throw a few things at the wall and start getting feedback early on. And that's why I'm here, more or less 4 or 5 days into the project. And I do, I'm sympathetic to the granularity push. And I think we still need to precisely figure out how we're going to crack that, because, it's meant to be comprehensive. So not to be an assessment of Overlake. It's meant to be, something more about the Washington state as a whole. But your point is that, well, the state as a whole is made up of a bunch of hospitals and a bunch of clinics. And so I get that. And I think we will push ourselves in that direction. And so appreciate the feedback. Dorothy?
Thanks so much. Just a great presentation and so systematic and organized and easy to follow. Really appreciate it. My question is one that would probably open up a new window, which is what you were asking, which is it linked at all? Are you able to link any of this in any kind of a data and analytics perspective with the quality of the care? So in other words, it could be a really good thing if for a particular clinical condition, somebody's spending more money because it's getting to better outcomes. Or, it could be that looking at the dollars that are spent in that sort of total cost of care perspective are yielding for the same amount of money, different outcomes. And so I think to get at Mika's point in even a little more pointed in my perspective would be if the whole point of all of this, and we have such an embarrassment of riches, I think, in terms of the capabilities that we'll now have in Washington State. It is the so what, and the so what to me is, that we're doing this all to improve the quality of care, the health of the population, as well as maintain the most reasonable cost profile that we can. But you can't just say that more cost is bad, although the clinical variation with the cost variation is sort of where I think over time it would be super cool to look at, even if you've just picked one clinical condition to begin with. So is it a good thing or a bad thing? Is 12% in primary care really smart for managing coronary artery disease, or is 5% there and 10% in cardiology, whatever it is. But I mean, to get at some more granularity, it was not obviously in the first year, but it just seems like if we have this level of data, and it sounds like you're going to have Medicare, Medicaid, and commercial insurance for the entire state. So you'll have access to more than the state has per se. Would be really, it sort of gets to the point of, okay, what is the payment methodology that's the smartest thing to do in Washington State? Sort of long-winded, but that was kind of what jostled my mind is listening to you.
Thanks, Dorothy. Yeah, thanks. Thanks for the push. And I do think the linking to quality is really important. It is to be super transparent. I don't think it's in the first year of work, kind of like you said. But I want to make sure that it stays on the table as a place, as a direction we can go, because I do think it is. And then B, kind of ensure that it's a part of the discussion, that there's not a spending conversation, a cost conversation that's divorced from an honest reflection of the limitations of what we have at the moment, which at the first stage really will be about spending and costs. But making room for the fact that A, we want to layer that on, but B, always need to be transparent about what we have and haven't measured, and to never overstate some of the concerns. So
thank you.
Thanks, Dorothy. Jonathan?
Yeah, I appreciate your presentation today. I keep coming back to informational versus actionable information, right? So there's a key difference between it. A lot of this is great to know, but is it actually actionable? And you mentioned something that really stuck with me, is having that strategic document, right? Do we have a plan to get to where we need to? Information is only as good as it is. Do we have a plan to break that down and actually make it actionable? So when we start looking at these large network providers and we're getting down to that granularity, that's where we have to have a strategic plan of how we get there, how we support this work, or otherwise we're just pointing out maybe what may be the obvious. So a big part of, I think, this work, I'm looking forward to seeing more around that document that you guys will be creating. But I think ultimately that's kind of what we've been missing as a whole, is that direction, is that document to get us from A to Z. And so instead of making that leap. So curious to see more when that is made available, but I appreciate your time this afternoon.
Thanks, Jonathan. Yeah, thanks. That's really helpful. And I appreciate there's a theme about granularity and actionability. And I appreciate that. Bob?
Thank you very much. It is really wonderful to watch IHME do this work. I'm kind of on the same theme in some ways. It's kind of the actionability, but it's also that you have a lot of data from a lot of other places. And my thought, and maybe that's completely foolish, but there are ways that people organize services, and I think that a lot of the stuff depends on having a system of care, not just individual practitioners, but how we fit into systems and how we do well that way. That finding places that have lower costs or better outcomes, or both, and that are comparable somewhat to us in some ways, that do things differently. It would be nice to kind of identify those. And I know this is way beyond probably what you're even thinking about doing, but I keep thinking about your vast database that you have, and particularly in Europe and other developed countries, that would be really helpful to come back and say, maybe the capital expenditures on these sorts of things really don't pay off as well as the investment in something else. And I think that kind of information would be dynamite for kind of guiding the policy approach that we may have to take.
Thanks, Bob. Do you, just to make sure, so one, there's been a big push in a lot of the folks that we talk with about identifying exemplars, identifying systems or places where things seem to be delivering as good or higher quality at as good or lower costs. And so that's kind of very much on, front and center on our mind. Wondering if your thought is, you kind of referenced international comparisons. Is that like within the state of Washington, or is that across the US, or is that bigger? Or, if there's a scope to start with, where do you think is most fruitful to begin that comparison?
Everybody only believes what they in their own backyard. So obviously local things would be helpful, but I think something in the United States, if there are examples, I would presume those examples are much more, I'll say they're larger, but difficult to organize from international comparisons. So I'm not going to be thinking I'm an expert in this area, but to have that thought in your mind as you start thinking about this, and whatever examples that seem like they may fit for the particularly if we find issues where there's a huge price increase or a huge problem with outcomes relative to other places, where we could actually focus on a few of those that I think could make a big difference. And I think having your data would be really good to help inform providers and systems as they start addressing these issues.
Great. Thank you.
Thank you.
Thanks. Any other pieces of feedback? I think we have just a few minutes left for this task, and otherwise can go on to the next agenda item. But yeah, Louise.
Thank you for the presentation, and I agree this is an interesting project. I'm wondering, in concurrence with some of the prior comments, when you start analyzing the data in geographic terms, I think a great deal about where I live in Olympia and the access to care issues for not just people in Olympia, but in the surrounding more rural communities. And when you start looking at care, cost of care, services provided within a county, one of the issues, of course, is whether or not services are actually available. So if you find counties where there's not a large amount of primary care being provided, is it because people aren't taking advantage of it, or because it's not available? And going to another county where it might be more expensive, but it might be more available, makes it easier for people to access. So just performing a geographic analysis is not in and of itself explanatory. It's simply a data point. And I really want us all to be careful in looking at that type of data to say, oh, people in these counties aren't really accessing primary care. But I know from having looked at ARNP workforce data that there are plenty of counties with very few ARNPs. And then when you look at places of employment, people who are licensed with a residence in a rural county might actually be commuting, or in a rural community might actually be commuting to an urban community to provide services because they get paid better in an urban community. So the access to care issue and the workforce distribution issue, I think, is a really important overlay.
Thanks, Luis. That's really useful. I think in our past work, we've always focused on the location of residence for the person seeking care, and not where the care is provided. That is not a blueprint of how we have to do it before, at the moment, but a lot of the data we've already analyzed is organized somewhat like that. So what you end up with is, patterns of expenditure that are not quite so, oh, everything's more expensive in the cities. That's to some degree, that's true, and in health to some degree too. But of course, people are coming from, surrounding communities to access, especially inpatient care, and even primary care as well. And so we see that when we look at kind of spending per capita or spending per beneficiary by location. We have never gone to the direction of assessing those patterns. I know there is research that have of people, essentially they're commuting for care. And so that is, I think, an interesting thing to be aware of and to consider more about. But at least at our onset, we're thinking of organizing around residents. Does that seem right to you? That's, and maybe we just need to do both, organize around residents and provider location. Yeah.
Well, I think if you organize around residents, then you know who's accessing care within that county or community. It doesn't tell you where they're accessing their care. So if you include, if possible, where they're accessing their care, that might actually be an important piece of information to look at what access to care really means.
Yeah, that's great. I wonder, thanks for raising that. I'm thinking about the data that we use most frequently. In most cases, it would be, we could essentially for a service or a health condition type of care, we could quantify the number of encounters that people are essentially accessing care in their own county versus commuting for care. That would be a relatively straightforward metric to create, and it could be part of essentially this data ecosystem of variables that we're looking at. And so looking to see what are the types of care, what are the health conditions, which payers are most likely leading to, I guess, that commuting for care that you described. So that would be, I think, something relatively straightforward to consider and to report on as well. It fits easily, it fits within this framework, and it's in the data we already have. So.
Thank you.
Yeah, thanks for the suggestion. Thanks, everybody. I appreciate the feedback. Like I said, it's the very beginning of the project. and we're very excited about it. And I'll be passing materials to the advisory committees as well as reporting over the course of the project to this group as well. So thanks in advance for any feedback, and thanks especially for the feedback and perspective today. It's really helpful.
Thank you very much, Joe. I know we're all looking forward to hearing more. Next, Ross McCool will lead us through a potential phase 2 options for the cost driver study, and look at the potential cost driver dashboard. Welcome, Ross.
Hello, everyone. Thank you. I will attempt to go through this at a good pace because I know there is something after this. So just for a little bit of context, the OnPoint presented some of the results from the cost driver analysis, which as a reminder is just right now a very broad look at APCD data, categorizing spending based on service categories that we see in the benchmark through the years 2017 through 2019. So now that we've seen some of these results, we want to get an idea of what to investigate next, what to look into. And some of the things we've taken inspiration from have been cost boards in other states because they are seeing similar results as ours. So I'm going to show some options. I'd like to get some feedback from all of you saying which ones you're most interested in, which ones you're least interested in. But also just as a reminder, if we don't go with an option, if we don't go with the option that's presented here, doesn't mean we can't pick it up later. Next slide, please. One thing I do want to mention is that of the categories that were increasing, that we saw increasing spend, was pharmacy. However, you will notice that there are no pharmacy-related analyses today. And that is because there's the newly created Pharmacy Drug Affordability Board. Then their whole work is involving pharmacy trends. So we want to make sure that we collaborate with them in the future, as well as not duplicate work streams. So I expect to hear more about PDAB in the future. Moving on to some of the work, some of the suggestions. First one is not entirely a suggestion, it's a refresh of the analysis. So we just want to update the cost driver analysis with newer data so that we can have as much new data as possible. I did want to mention it though, because it is not a small amount of work to do this. Next slide, please. There was interest in some of the committee meetings about having additional chronic condition flags. We can fairly easily add some more flags from the Chronic Conditions Data Warehouse, or CCW. We can add other flags. It will require more resources. Some of the other flags that were suggested were chronic conditions for infants and groups like that. Next slide, please. As a little bit of a recap, what we saw was in 2017 through 2019, we saw a slight decrease in spending in inpatient, but then a increase in spending in outpatient. So next, I'm going to discuss a few analyses that might be able to peel back the onion to figure out what's going on there. So the first one is looking at overall price growth for these two, looking at trends in volume of service, price per service, stratify these volume and price by facility type and geography, really try and dig down into what the differences are in these two areas. Next slide, please. Another interesting analysis that other cost boards are doing, and I think several other institutes are doing across the nation as well, is looking at severity and complexity of services. So for inpatient, we could look at changes in severity, like types of DRGs, look at changes and trying to account for age, gender, payer type, region, etc. And then for outpatient, the same thing, but more focused for outpatient, such as severity and complexity. Next slide, please. There are a few cost boards have also done an investigation where they looked at services being rendered from an inpatient setting to an outpatient setting, and seeing that transition actually increases the cost of the service price. So we could do something similar where we look at maybe the most expensive services, or look at ones that have maybe ones that appear in both and have the largest discrepancy between prices, and then try and look at and see, is it different case mixes that are accounting for this, different DRGs that are accounting for this, try and dig down into, is this happening? And if so, what are the descriptives around this transition? Next slide, please. We could also do analysis on out-of-pocket spending, look at how much out-of-pocket patients are having to pay for their services. And then I think the next slide is the last one. Oh, no, we got discussion. So I know that was very quick. I was trying to make sure we got to the next thing as well. Yes, Mika.
Yeah, thanks, Ross. You know, looking for things like the inpatient to outpatient transition in the data is obviously going to be important, but from a practitioner standpoint, we've been driving to this for the last 20 years, minimally invasive surgery. CMS and insurance company drivers to reduce inpatient stays for certain procedures like hysterectomy, like hip replacement, that kind of thing. There are powerful regulatory, insurance, and technological changes which are driving this. And I just want to be sure that you're not only looking at the data, but taking into account what, like a focus group, what are you trying to do? Where are you going? How has it changed from your perspective? Will provide, I think, a lot of important context. And you won't have to necessarily use the data to figure out, did this really happen and why is it happening? We've been trying to do a lot of this.
And that is a good point. We're using the data in order to come up with talking points, try and see if there is some consistency across different regions, groups, different types of descriptives, see if there is some sort of change that we can come together and talk about to figure out how to make this, affect price growth in a beneficial way for everybody.
Thank you.
Any other feedback or thoughts for Ross?
Ross, Mika, and just one follow-up question. We heard about the proposed report from the board that's going back to the legislature at the end of the summer, in the fall, sort of thing. Are you thinking that your data analysis will go into that report? And if so, will the advisory committees have a chance to see either the data or the report before it's submitted? Do you know?
Are you referring to having this phase 2 data in the report?
Correct.
This will more likely take longer than when that report is due to accomplish, because this is peeling back another layer. We've got to take a lot into consideration, partly of things you've talked about already. But this is going to be a basically year 2, phase 2 process. It will not be ready before that report is due.
So the data in that report is going to be at least a year old.
I apologize. I'm not following you.
Well, I mean, if the report includes any data and it's not been updated, it has to be the previous iteration of this, which is at least a year old, maybe 2 years old.
I think you're talking about the data for the cost driver analysis, and currently that is a historic look for 2017 through 2019, as well as for the benchmark data call, which was 2017 through 2019. That will have old data as part of its design, so that we can see what has historically happened before getting new data.
Okay, thank you.
You're welcome. Thank you. Don't. I don't see any more hands raised or questions in chat.
Don't see any either, Ross. If you wanted to, I know that you have one more item to present.
Okay, I will attempt to share my screen. Oh. To share the screen. Okay. Click share. Okay, so this is a preview of the cost driver analysis dashboard. This is not the final version. It is still going through final review. We just wanted to give the committee a chance to take a brief look at it. This is the cost driver analysis data that was presented by OnPoint earlier. But we just want to be able to put it up on our website, the WA Health Compare website, so that everyone will be able to have easy access to this data, or rather to this dashboard. We have 4 sheets. The first one just looking at trend from 2017 through 2019. Under choose a measure, there are several service categories, many of which are similar to what is found in the benchmark data call, because we want to have some overlap there so that we more easily figure out where we want to dive into more analyses for APCD data. The second sheet is a measure drill down, where we can get a little bit more in-depth information, because we can sort by different areas such as gender, age group, ACH region, county, etc., and as well as gender, age group. So we can do kind of a cross-sectional to see what is going on for these different measures that we have. You'll notice that this includes data from 2017 to 2021. However, it is missing Medicare fee-for-service data for 2020 and 21. That's why we don't have that on the main page, because we do not want to add confusion. That will be updated as soon as we get that information loaded into the APCD. I think there's just a slight delay from CMS for that. The third is a measure map, where we can see some information about the measures from different counties. We can also sort by ACH region. And then finally, we have a sheet to look at spending associated with chronic conditions, so that we can sort different chronic conditions. We can either see all, or we can just pick a few and see how spending is compared to all members for these chronic conditions. That is the very quick version of that, and I will hand it back to Mandy.
Did we want to have any questions? Does anybody have any questions about the dashboard? Sorry. Can we have Ross talk about where? Oh, yes. I'm sorry, Ross, would you explain a little bit more about where the web page will be posted when it's ready?
So the website WA Health Compare will have a new section that will be located at the header, if you'll be able to click on. That will be a web page that will have this dashboard, as well as we will start to collect links to different resources that are using the APCD data, so that we can link to those, so we can get kind of a cohesive area for APCD data use, so that we can start linking to and seeing different studies that are happening in the state.
And do you know when that might be available on the dashboard? The dashboard might be available on the webpage.
The dashboard is going through final review, so I'm hoping soon, but it's a process.
Understand. Any other questions from anyone? Thank you, Ross. And I know that there was a motion on the table. I did see that there was also some requests from other members to delay any motion so that they have the opportunity to also hear the motion. I'm wondering, and I think Mika, was it you that suggested a motion?
Yes, Jonathan Bennett and I both wanted to bring forward a motion following up and expanding on the points that Jeb Shepherd and Katarina LaMarche raised in the open comment section. And I saw Leah's comment, but you know, the motion really addresses the discussion points that have come up over and over again about actionability and accuracy of the data. And I do think it's an urgent issue because we want this motion to get before the board. If we could at least present it, and then Leah and others who have either dropped off or not been able to join us could comment afterwards, as opposed to delaying it.
I think it would be a good idea to present it, and then if you have any supplemental paperwork that you have, that's fine, and perhaps we can vote it at the next meeting.
Great. So I have, I think, let me just make sure that okay, it should be in the chat now, and I'll just read through it. The joint committees respectfully request that the board address the following critical operational elements as they relate to healthcare cost growth benchmark process at an upcoming board meeting. First, methodology. How will we fairly attribute numbers to providers? Because providers will be held accountable to the benchmarks for those patients. You've seen a lot of the questions we've talked about today about actionability deal with that issue. Data accuracy. How will data be attributed and verified to providers? Because this will determine compliance with the benchmark. Risk adjustment, which was not commented on really in any of the discussions today, is an essential requirement to account for appropriate health care intensity of attributable members, because risk-adjusted health status will impact the scope, magnitude of services, cost, and outcomes, and must be fair, equitable, and consistent. And finally, metrics for provider performance. What key metrics will be considered the contributors to cost growth? And we've just seen a summary of some of those, because an underperforming provider must be able to understand why and see how to fix it. And of course, that gets to the granularity issue that we discussed in the IHME presentation, that at a county or city or zip code level, it's very hard for a healthcare provider to respond. They need to see it at an individual physician, clinic, hospital, medical center, and health system level. And we've not yet seen a way to attribute that kind of information accurately. So that's the motion, to be sure that the board is considering those issues as they continue with this data process.
Yeah, and this is Jonathan. I mean, early on in the process, we talked about key considerations. And some of those considerations were having a high degree of confidence and accuracy and reliability of the data. We also talked about the data completeness. We talked about the workload and the process to collect, validate, and analyze this information. So having more transparency into that process, I think, is going to pay dividends down the road. So that's why we're wanting to take a step back and have that conversation as well.
Great. If you have some materials you'd like to share in advance of any motion discussions, that would be great for the next meeting. You can always email me, every member of the board. I want to thank everybody for attending today. The recording and summary of this meeting will be posted shortly on the website. And thank you again to all of our presenters today. Next meeting of the Advisory Committee of Healthcare Providers and Carriers is September 7th at 2 p.m. And the next meeting of the Advisory Committee on Data Issues is October 3rd at 2 p.m. And I look forward to seeing everybody at the next meeting. Thank you, everyone.